Yes, ma'am, we are live.
Good evening, everyone. I welcome you all to the 23rd webinar hosted by Nephrocon. You can, it is with great pleasure that we are continuing the BANFF series. Last month, we had a discussion on ABMR, and this month, we have a session on TCMR, that is T cell mediated rejection. So T cell mediated rejection matters the most because it is the most treatable and prognostically significant kind of injury after transplant. And if detected, it can be treated if diagnosed on time. So for that, I'd request Dr. Alok Sharma sir to join us and continue his or begin his talk on T cell mediated rejection. Dr. Alok Sharma is a nephropathologist from New Delhi, working at Lalpath Laboratories, and he frequently sees our kidney biopsies, native kidney and transplant kidney biopsies. So it's a pleasure to have him. Dr. Alok sir, over to you.
Thank you, Dr. Purva. And thanks again for having me again on Nephrocon. And it's really turned out to be a great platform for discussion of nephrology as well as nephropathology across the country. And I really kudos to you for that and your team for that. And first of all, a very happy Teachers' Day to everyone. I think that's an important day on which we are having this meeting. And so we'll talk about PCMR and as Dr. Purva told, it it is one of the most if diagnosed in time and diagnosed well, it gives one of the most gratifying responses in terms of clinical response. And but on the other side of the table, diagnosing it may be a challenge because it overlaps with a lot of non-immune injuries, which we are now realizing. So previously thought that any inflammation amounts to TCMR, but now, in fact, in the last BAM, this was a very important discussion around this, that we should be able to distinguish the immune response leading to rejection from the non-immune and treat accordingly. So maybe I'll briefly touch upon that aspect as well in this. And of course, the incidence as a isolated entity is going down, thanks to the great immunosuppression regimes which we have evolved. But still, that what has that done? It has given rise to more complexity in terms of histological picture. So a person who is sitting at the microscope and also conversing with the clinician needs to be aware of the complexities, lest you should give a more complicated diagnosis, which eventually will not lead into any actionable treatment. And I think this particular slide, we are well aware of the timeline of the renal allograft. And I keep on putting this in my presentation just solely to tell you that so many things occur together in a renal allograft that any diagnosis or any interpretation we try to make of a tissue biopsy will always remain a very complicated process, because all these processes in some form or the other always go on in the kidney. And depending on where the balance has shifted in terms of immunosuppression, the clinical presentation and the histological pictures rise. So I think this timeline will remain as it is. It's only our interpretation of the factors or the processes which happen in this timeline will eventually lead us to the progress in this field. So coming to BANFF directly, so this is a relatively simple in terms of histology. It's not a very complicated topic in terms of histology, but as we dissect more layers of T cell mediated rejection, as I go up in the second part of my presentation, you realize that it is not as easy as it appears to be. So we were all aware of these 6 categories of BANFF, and what we'll focus on today are these 3 and 4, and of which 3 is actually the Achilles heel or tendon, if you want to call it, of transplantation pathology, because that is where most of the problems arise, both in terms of diagnosis as well as treatment. So this borderline suspicious acute T cell mediated rejection still remains an enigma, and we need to sort this thing out so that more actionable insights can be got into further. So we will briefly touch upon that as well. So as a renal pathologist, when I look at this kind of a picture, this is what tells me that I'm dealing with, of course, in a transplant biopsy, I am looking at a T cell mediated rejection. So a lot of blue, if you can see in this picture, and that blueness is caused by the staining of the nuclei of the lymphocytes, right? Mostly mononuclear cells. And that's where the main difference between a T cell and an antibody mediated rejection. The T cell is more of an immune response in terms of immune effector cells, whereas the antibody-mediated rejection is more of an endothelial injury. So these two things often occur together, as we will see later on. But as far as pure T cell mediated rejection is concerned, these are the effector cells of T cell rejection, which appears as blue in the biopsy. Now we'll quickly go through this. So this is from the BANFF classification. This is the classification didn't change, by the way, in the last BANFF meeting, at least for the T cell mediated rejection. So we are still there where we were in terms of classification. But a lot of new discussions emerged in the last, and I think in 2026, we will see a lot of new categories getting added to the BANFF classification, which I'll just briefly discuss in the last part of my talk. So currently we have these 3 and 4 categories. The category 3 is, I told you, the borderline rejection, where we are not able to meet the threshold for inflammation. So I told you, I showed you the last slide where there was a lot of inflammation. That definitely was more than 25% of the non-scarred cortex, right? So definitely that was crossing the threshold. But more often than not, that inflammation does not cross the threshold. And we'll come to tubulitis. All of us know what tubulitis is. Inflammation, the presence of lymphocytes in the proximal tubules, which are not atrophic. And many times it happens that we are not able to reach those thresholds which have been defined by BANFF. So those cases where the threshold for an acute T cell rejection are not defined, we call them lesions which are suspicious for T cell mediated rejection. So over a period of time, what has become, it has become a separate category by itself. So it started off as kind of an experimental category where it was hoped that clearer treatment regimens would appear, and probably we'll be able to get rid of this category over a period of time. But what has happened, this has stayed on, and in fact, it's become one separate category by itself. But I think we are well on our way to excluding this, and there are more things which are going on in this world. Now, once the threshold of inflammation more than 25% and more than 5 cells is breached, we come to the TCMR. And there are 3 types of TCMR. Of the first category, the grade 1 TCMR, predominantly involves the hallmark lesion is the tubulitis, right? In the lymphocytes actually crossing the basement membrane of the tubules and attacking the tubules. That's tubulitis. And depending on how much tubulitis is there, we grade it. So we'll come to that in a moment. The second part, the grade 2, if you want to call it, it's completely different. So, and there are a lot of discussions around this. In one part, we are calling T cell mediated rejection as a part of the lymphocyte effector cells on interstitium. Now, the same effector cells, when they start reaching the endothelial, the subendothelial areas of the arteries, we call them as a BANFF grade 2 rejection. So that's called intimal arteritis or end arteritis or endothelitis, whatever you can choose to call whatever it is. But basically, we are looking at arteries here. We're not looking at arterioles. So then once you have this feature of intimal arteritis, the inflammation becomes non-relevant. So however inflammation you may have, you still have to call it BANFF grade 2. Again, there is a caveat here. So there are cases where you have V, there may be a V, but there is absolutely no inflammation or microvascular inflammations. So those lesions are called as isolated V lesions. And there is a lot of clinical and pathological discussion around how you should manage these, what is the eventual outcome of these isolated V lesions. And even that is being addressed by the current BANFF committee, and probably we will have some guidelines next time. But as for now, any V lesion, even if it is devoid of any inflammation in terms of interstitial inflammation or microvascular inflammation, which signifies endothelial activation, is still put under the BANFF grade 2, right? So we really don't have a clear-cut guideline to that, but there are some things which are emerging, which we'll take on later. And in the part 3, the class 3, grade 3 TCMR is the one which is most severe, in which you can see necrotizing vascular lesion. So this is what the general schema of acute T cell mediated. Now, once there is acute, the more problematic area is the chronic rejection, right? And there has been some progress in terms of diagnosis of chronic rejection, T cell mediated rejection over the maybe the past 7 or 8 years. But still, there are a lot of areas which need to be addressed. So as of now, the TCMR, the chronic active TCMR, is graded in 2 parts. The first part is predominantly based on the IFTA concept, which we will come to in the later slides, and the grade 2 IFTA, which is predominantly an arterial lesion in which immune effector cells have infiltrated. So this is just a brief about and this is what is T cell mediated rejection, right? So the category 3, where the criteria of threshold are not met, and category 4, where you have an acute or active T cell mediated rejection and a chronic active T cell mediated rejection. This is all is T cell mediated rejection in terms of pathological diagnosis. But of course, there are many layers which we will slowly cover. Now, as we have seen, uh, we just spoke about some lesions. Now, if you want to master the art of diagnosing T cell mediated rejections on a better basis, what we have to do is we have to be well aware and conversant with these scores. Um, so these I scores, so it may appear like a jargon, but actually this is what creates the report and the impression at the end of the day. And unless a renal pathologist or a nephrologist sitting at the microscope together are not aware of these lesions, are not thorough, have not mastered these lesions, a very, very small mistake or a small misunderstanding can place a lesion from here to there. So we have to be very sure about how these lesions are graded in terms of a biopsy, and also what is the implication of these so-called scores when you actually make a composite score out of it and give out a diagnosis for treatment. So the inflammatory scores, that is the inflammation in areas devoid of interstitial fibrosis and tubular atrophy. So right from the beginning of BANFF, the fibrotic areas in kidney allograft biopsy have been a cause of concern for renal pathologists. So we actually have never been able to come to a very comfortable zone in terms of these atrophic areas and inflammation which occurs there. So previously there were different kind of guidelines, but now we are giving equal attention to even these fibrotic areas. But in terms of activity or the acute lesions which need treatment, these areas are excluded. So when we talk about I score, we are talking about inflammation where there is no tubular atrophy or interstitial fibrosis. The T score is the tubulitis score. We'll come to that in a moment. Again, it's a crucial score which defines the T cell mediated rejection, where the lymphocytes actually cross the basement membranes and enter the tubules on the basolateral membranes. And depending on how many lymphocytes are there in a cross section, we keep on grading them. One, it's a hierarchical grading. More the number of lymphocytes, the higher the grade, right? So that's how it happens in almost all the categories of lesions. Now, similarly, there are scores which are CI scores. So how much is the extent of cortical fibrosis? How much is the extent of tubular atrophy? And then I just spoke about in the initial part about the inflammation in atrophic area. So I think in 2015, first this concept was proposed. So we started paying attention even to inflammation in areas of atrophy. Previous to that, we just used to exclude it. So whatever inflammation is there in atrophic areas, we just used to close our mind towards it and let it be there. We used to just focus on the inflammation which was in the areas which was scarred. But eventually, it was realized that even that contributes to long-term graft prognosis, right? The inflammation which is there in the chronic areas also determines or alters or reduces the graft survival. And that is where more attention was paid to it. And now there is a category which is called as IFTA, that is inflammation in areas of tubular atrophy and interstitial fibrosis is a separate category, and it is one of the hallmarks or a diagnostic criteria for a chronic T cell mediated rejection when you exclude other etiologies. So this is the importance of IFTA. And the new category was introduced in 2019, I think, which was called the STIFTA. So this category does not have a diagnostic place as of now. People are there are a lot of groups which are working on TIFTA. TIFTA is basically tubulitis in areas of atrophy and fibrosis. So what we talked about tubulitis earlier was only in non-scarred areas. But when this tubulitis occurs in scarred areas, it is called TIFTA. And it is graded similar to IFTA. We'll come to that. I'll show you the classification schema. But it's good to remember here that this is still under evaluation. And although it does not find a diagnostic place, so using TIFTA, you can't diagnose a chronic active rejection or any other category, but it's still being evaluated in terms of its utility in grafts. Because if you are evaluating inflammation, you should also evaluate the tubulitis associated with it. So that's the criteria of using it. And finally, the V score, which we just talked about in terms of intimal arthritis. So these are the basic 6 or 7 things which we need to be well aware of when we are trying to diagnose a T cell mediated rejection in an allograft biopsy. Now, we talked about I score. And the reason I put up this slide is we all know this scoring criteria 10, 10 to 25, 26 to 50. But what not many people pay attention is that there is a way to go about it. And which are the conditions which you have to include and which you have to exclude. So that's an equally important part of taking this forward. And once you've seen that how much inflammation is occupying how much area of non-scarred area of the cortical, you have to ensure that uh, nodular infiltrates, if any, and if they're present in non-scarred areas, and trust me, they often occur more often than not and they are excluded, they have to be included in the inflammatory score. It can change your diagnosis from a borderline to an active T cell mediated rejection. So the nodular infiltrates of lymphocytes in areas of atrophy are equally important. In non-scarred areas are equally important and they should be included. Secondly, when I talk about inflammation, I do not specifically, the BAMF does not specifically talk about only lymphocytes, right? It also tells you. So when you look at I score, everything has to be included. So you have to include lymphocytes as well as macrophages and even eosinophils, neutrophils. But when you identify cells which are apart from lymphocytes, you have to put in asterisks and try to figure out what is the percentage of those cells in that inflammatory infiltrate. Neutrophils, of course, they will lead to a different diagnosis of pyelonephritis and infectious etiologies. But plasma cells, eosinophils will tell you an allergic etiology. Again, we'll come to that. The plasma cells again are a very troublesome entity, and there is a separate category which is fairly well characterized of plasma cell rich rejection, which need to be taken care of. So if you have more than 10% of plasma cells in your infiltrate and you are looking at an overall picture of a T cell mediated rejection, then it is a good idea to put an asterisk, which also BAMF also recommends and tells how many percentage of those non-lymphocytic cells are there in the biopsy. So all these things should become a part of your report. And secondly, inflammation in the scarred cortex, immediate subcapsular areas, and adventitia around large veins is not considered. So don't include those inflammatory scores into your I score, otherwise you will unnecessarily inflate your I scores. So I just talked about plasma cells. So I recognize this long back. So this is a very peculiar, so very resistant to treatment also. I'm sure people who have encountered this plasma cell rich rejection have faced this, and it's a really difficult entity to treat, and it really progresses recalcitrantly. And the idea is it is the plasma cells which should be causing tubulitis. It's very important to note that it's not just the lymphocyte. So the presence of plasma cells versus the plasma cells themselves causing tubulitis is a very important part where you should be able to distinguish the two. And only when you see plasma cell tubulitis, you can see in this particular case, then you call it a plasma cell resolution. So this I think is a paper, our paper from long back, 2012, but it's still there. So it's now it's fairly well characterized, and those plasma cell rich rejections are still happening. They've reduced in for some reason. They have maybe because of reduction of TCMR, they are not as frequent. But trust me, I used to see biopsies earlier in 2012, 13, there used to be quite a few of plasma cell rich rejections. Now coming to the continuing our inflammatory score, if you look at these two pictures, one on the left side, which is of a relatively low power, and one on the right side, you can see that there are inflammatory infiltrates which are occupying areas which are devoid of tubules also, and there are areas where there is no atrophy, but you can see a few cells which are actually going across and causing tubulitis. So where my pointer is right now are the areas of tubulitis, and you can very well see there is no atrophy here. The tubular membranes are fine. So these are areas of tubulitis which we were referring to. Now, another important concept which often is ignored is the areas of atrophy. So where do you score this inflammation and tubulitis is also very important, right? I talked about scarred and non-scarred cortex, and identifying this threshold where you don't score those areas of tubulitis is very important, right? Even in terms of atrophy and fibrosis. So when you have very mild atrophy, so if you can look at this picture, the left part is relatively okay, right? There's hardly any atrophy. But if you see on the right side, maybe there is a very mild atrophy of these tubules. So you can still score in these areas, right? So mild atrophy is allowed. Similarly, now the atrophy, if you look at these tubules, this is the PA stain section. You can see there is some wrinkling of the basement membrane, but it's still not severe. The reduction is not more than 25% to 30% in this. And if you find tubulitis here, again, you should be able to score this. But when you look at the next picture, this is severe atrophy. So any tubulitis which is occurring in severely atrophic tubules should not be scored. So if you start scoring those tubulitis, even for a T cell, acute T cell mediated rejection, you will of course do that for, but other you should not be scoring it for any kind of scoring activity in BAM criteria. And by the way, severely atrophic tubules should not be scored. So they are not a part of any classification schema, and severely atrophic tubules are not to be included in any of these scoring criteria. Now, when we look at biopsies, there is a special type of atrophy which is called as endocrine type atrophy. The reason why it is called endocrine type, because when we see other organ biopsies, the endocrine tubules look like this, the ones which I'm encircling right now. Now, this particular type of atrophy, although it does not show thickened base membranes and other things, it's still counted under severe atrophy. So a pathologist should be very well aware of what he or she is looking at, and which areas are being scored for tubular atrophy in interstitial fibrosis. So tubular atrophy of endocrine type is always severe, and one should avoid scoring tubulitis in those areas. So this mild, moderate, severe, and endocrine should be well ingrained in the mind of a person who is actually looking at the transplant biopsy and trying to diagnose the T-cell mediated rejection. So we talked about the tubulitis scores, and when I started practicing long back, the distinctions were not very clear, and even there were mistakes where even a single focus of tubulitis, although the criteria were very well there, they were not very people were not very conversant with those criteria. And BANFF very clearly tells that if you want to diagnose the T cell mediated rejection, even if it is a borderline T cell mediated rejection, you should have at least two foci. So there have to be at least two or more foci of tubulitis. So if you have just a biopsy with a single focus, even if it is non-neutrophic of tubulitis, you're not going to call it a TCMR, right? So that criteria, and I have seen a lot, I even still see a lot of biopsies which come for second opinion, where single focus of tubulitis in a biopsy has been labeled as a borderline TCMR. So I think that is what has led to an overdiagnosis of borderline TCMR, because probably the guidelines are not being followed very rigidly. And trust me, see, rigidity is not something which we encourage, right? But those basic criteria which are there for diagnosis have to be followed. Otherwise, we will not be able to compare the outcomes. So that's very important thing. So those two, I again emphasize, there have to be at least two foci of tubulitis for you to be even thinking of making a diagnosis of T-cell mediated rejection. And then, of course, depending on this hierarchical grading, 1 to 4, 5 to 10, or more than 10, it becomes T1, T2, 3. And a special mention I want to make here, and which is again overlooked by a lot of people, is the T3. So T3, of course, one part is very clear that you need to have more than 10 cells, but there is another part where you can have lesser than that, but there is a destruction of tubules. So when you see there is a loss of basement membrane of tubules, you can call it a T3, even though the criteria for tubulitis is not being met. So these are small snippets. And if you look at this biopsy, you can see this is a nice inflammatory area, good tubule, which is not atrophic. And if you just count the number of cells, this is 4 cells, right? So depending on what the other part is there, this 4 would come into a category of T1. Similarly, you have a T2 where you can see a lot of cells, but still less than 10. And this is the T3 I was referring to. So there are definitely more than 10 cells in some of them. And in this particular tubule, which has been marked, you barely can see the basement membrane. So it has been destroyed. So in this case, you have to follow a different, you can call it T3, but even if this is there and you don't get T3 lesions more than 10, you can still label it as T3. So those are the different kind of tubulitis one should be aware of. Now coming to the V score. Now V score again, it's easy. So identifying internal arteritis is a very comforting feature for a renal pathologist, because once you see a V lesion, you are almost sure that there is a rejection process going on, right? But barring that isolated V lesion gives you a fair idea of that rejection is going on. And then once you see a V lesion, you put it in context. So I'm sure all of us know that V lesion is a component of both AMR and ACR, right? So that V1, V2, V3, it is a part of BANFF grade 2AB in TCMR. And again, it finds a place, intimal arteritis finds a place in ABMR as well. So what you decide in terms of where you put it, so either it is a mixed rejection, you see features of both microvascular inflammation and affected tubulitis and other things. But if your background is just MVI or microvascular inflammation, you place that intimal arteritis into an ABMR. Or if you don't see microvascular inflammation, you put it as a part of TCMR, right? And then you grade accordingly whether you are trying to grade it. Barring that isolated V lesion or suboptimal biopsies where you have to follow a path which is most suitable for that particular given case. The most severe is among these is a V3 where you have transmural. Transmural means involving all the layers of the artery, right? So that's called a transmural arteritis and or fibrinoid change. So even if a single focus of fibrinoid necrosis is there in an artery, you will label it as a V3, and it has a very poor prognostic uh, factor. V3 lesion is not a good sign for the graft. Similar to native kidneys, wherever you, even if in an ANCA-associated gene you find necrotizing arteritis, you say it's a bad prognostic indicator, even in anti-GBM. So similarly, fibrinoid necrosis of an artery is put in V3 and carries a cardiac prognosis. And this is how it looks. So on the left side, so all these images are from the BANFF teaching. So if you go to the website of BANFF Foundation, you will find a nice teaching set there. And it's a very good compendium of images which are classical. So these images have been put on the website after a lot of research, and they actually confirm to the exact lesions which BANFF is trying to propose. So one can go to the BANFF Foundation website and have a look at these images, which is a teaching set. And I've taken most of the images in this presentation from that particular set, which is free to use for education and teaching purposes. So in this left side image, you can see there is a intimal arteritis. You can see these lymphocytes, which are mostly CD3 cells, which are just below the endothelial cell. So this is called as intimal arteritis. Now BANFF has a very interesting take in this, which is now again being debated. So BANFF says that even if you find a single lymphocyte, a single CD3 positive or a single lymphocyte, if you can identify in morphology, it is enough to label it as a V lesion. Now, experts over a period of time realize that this may not be true in all the cases. And the BANFF group is now again looking at lesions. Is a single cell enough to create or to give a diagnosis of V lesion, which will again result in a significant amount of therapy given to that patient? So that idea of a single cell in a subendothelial space again is being relooked. And I think we'll have more guidelines in the coming 2026-27 BANFF again to that. But as of now, it stands. So even if you identify a single cell, you have to call it a V lesion. So that's one part of it. Secondly, since it's a hierarchical classification, the more the so this particular classification is not on the number of cells up beyond that one. It is on the amount of lumina which is being compromised. So whatever lumen is there, the progressively it starts getting compromised because of edema in cells, and we start getting these V2 and V3 lesions. Right? This is the V3 lesion, and the area which has been marked here, which I am encircling right now, is an area of fibrinoid necrosis. And to identify fibrinoid necrosis, it is a good idea that you do a Mason's trichrome stain on all your biopsies. And it is very difficult to identify fibrinoid necrosis in any other stain. And in Mason's trichrome, it stands out like a bright red granular material. And it's a good idea to do Mason's trichrome for all your biopsy, not only for fibrinoid necrosis, but also to judge the extent of fibrosis. So the Mason's trichrome stain stains the fibrotic areas blue, and even most of the image analysis or the uh, machine learning algorithms which are being created now to judge fibrosis are based on Mason's trichrome stain. So that blue color gives a nice picture of the extent of fibrosis in a kidney biopsy. One more part, although it's not a part of TCMR, I would still touch because that image is here, is of the interstitial hemorrhage. Now, this is a subtle finding. So it's not, it's a diagnostic that it doesn't have grade. But if you find areas of interstitial hemorrhage, it denotes endothelial injury, and you put an asterisk there and you say that I have seen interstitial hemorrhage. And most of the times, interstitial hemorrhage is associated with an antibody mediated rejection, not a T cell mediated rejection. So this is all about V lesion. In 2020, I think after the 2019 BANFF meeting, the paper which came out in AJT after 2020, we realized that now the time has come to divide the BANFF. So there was a lot of all khichdi, right? So like ITV, CIT, C, IFTA, TIFTA, and all those things had started coming. So we really didn't know where to put them in terms of report. And when a clinician or a pathologist writes a report, it is also a good idea to so we give of course, so depending on where we are practicing and how we are practicing, we always give a score, right? I1, T1, whatever it is. There are different criteria which we give. But going a step further, it is not a bad idea to actually divide these scores into three parts. I'll tell you why it is important now going forward into BANFF 2026 is that so acute BANFF scores are I, T, V, G, PTC, C4D, right? So they denote the active part of the lesions which are happening. Pure chronic parts are the CI, the interstitial fibrosis, the tubular atrophy, the chronic vascular changes, CV, which will come to that in a moment. The CG, when you have been talking in terms of chronic ABMR, and PTCML, which is again an ultrastructural finding. So these are pure chronic. And then you have a mixture of acute and chronic, right? So TI, IFTA, TIFTA, PVL, which we're talking in terms of polymer virus nephropathy. So these are acute and chronic BAM scores. And then they are graded as per their usual criteria. Now, what is happening in 2026 going forward is there is a committee which is looking at creating activity and chronicity scores for transplant biopsies. So similar to what we have in lupus nephritis, we have an activity score, we have a chronicity score. I think from 2026 we will have a composite score where you will be able giving a activity score to that biopsy, and you will also giving a chronicity score to that biopsy. And dividing these lesions in these three parts in a biopsy then would come handy because the scores would again be based on these particular lesions. So this three part, I'll come to that again when we take that 26, 25 update. But for the time being, we can remember that it's a good idea to distinguish the active chronic and active on chronic or active and chronic lesions in a transplant biopsy report. Now we talked about the threshold for diagnosing active TCMR, right? And grade 1 TCMR we need. So I2T2 is the formula which we have to keep in mind. So I2 is inflammation in equal to or more than 25% of the non-scarred cortex. Again, two foci, minimum of two foci. And T2, that is tubulitis of equal to or more than 5 cells in the most affected normal, mild, moderately atrophic tubules in a non-scarred cortex. So I apologize for the typo there. It is non-scarred cortex. So these are the thresholds which we use to start diagnosing acute or active T cell mediated rejection. Now, having said that, now come to the borderline part. Now, this is probably the Achilles heel, and we are still struggling. All the clinicians, I'm sure everybody who gets a report of borderline changes, at least at the back of the mind, you give out a curse to the renal pathologist that what do I do with this case, right? And trust me, we are in the same position because the criteria is still not very well defined. But what borderline means is that we are not yet there in terms of I2 and T2, right? So anything below that in non-scarred cortex constitutes a borderline T cell. Borderline features suspicious for a T cell mediated rejection. And depending on the overall clinical scenario, there will be a decision to treat or not treat will be taken by the clinician. But by itself, it does not give you an indication whether it should be treated or left alone. So that is the problem with this particular borderline changes. As you can see in the right side, it's the same image I'm telling you. It's still 4 cells. And if you carefully look at this particular tubule, there is only a single cell or maybe 2 cells in this particular tubule. So these are not reaching that threshold of T2 tubulitis, where we can call it a grade 1A kind of a cellular rejection. And recently there was a paper here, I think it's 25, yeah, it's a 2025 paper, which actually tells that this is the Achilles heel, right? And what this paper does is, so I'm sure all of us know, since 2013, the gene transcripts have been there in the BANFF classification. But there have been a lot of problems in terms of adopting them, in terms of complexity of technical expertise required, and also the costs involved, which have prevented the use of transcripts as a routine in diagnosis of cellular rejections or basically in a BAM scheme of things. But this paper is a fantastic paper. I suggest everybody please go through this paper. It's free. It's an open access article. And what it has done, it has given very good insights into why you should be using gene transcript and transcript classifiers as a part of your routine biopsy screening. Because this particular category, if you want to get rid of, I don't think so we can do it by morphological means. We have to use something beyond this to be able to get rid of this category and to make our classification schema more actionable in terms of treatment. So I think that is where we are heading slowly. And this is a very good paper towards that start. Now, we've talked about this ACR. I think we need not go into details of this. Active TCMR, similar to what we have told earlier. So depending on how much inflammation in a progressive hierarchical grade, the tubulitis, the more the number of active tubulitis beyond the threshold, you will keep on increasing it to 1A, 1B. Moment you see intimal arteritis, you will put it into type 2, AB, depending on how much luminized thing. And finally, if you have a transmural arteritis or fibrinoid necrosis, you put it as V type 3 active TCM. So that's an easy diagnosis. The main problem comes again now where there is chronic. So I am again putting that slide here and asking you to look at the chronic BAMF scores. And these are the areas which have a lot of overlap with non-immune inflammatory components. And the diagnosis of a chronic TCMR is still a very difficult diagnosis to make from perspective of a renal pathologist, because most of the times, many times, we are not aware of what all the other things happening to this patient. What all therapy is he receiving? What are any drugs he's taking? So the non-immune causes which can induce inflammation in the allograft, combined with the areas of atrophy in the graft as it progresses its life, are the ones which create most of the challenges in making a diagnosis. So to that effect, the IFTA was actually taken up, and the CV lesions, we've taken that up earlier. And IFTA was the one which actually came into picture in 2015. I'm not recalling 2015, I think. And then that was included in the diagnosis to make a chronic T cell active T cell mediated rejection, provided you exclude all other causes of inflammatory component in the allograft, which is again a very difficult task. Anyways, so the vascular lesions which are associated with chronic allograft injury again have a hierarchical pattern. And depending on the amount of fibrointimal sclerosis which you see in the intima, they are graded as CV1, CV2, CV3, and so on and so forth. So it is the same criteria which applies. So how much of the area you are occupying. So this is the BAM Foundation group score, which tells you CV1, CV2, CV3, and again, how much is the luminal area of reduction. So 25, 50 or more than 50, you will label as CV1, CV2 or CV3 lesions, depending on how much intimal fibrosis is there. And if you start seeing cells also, mononuclear cells in a subintimal sclerotic area or along the walls, then you give it a diagnosis of a transplant arteriopathy, which is again a lesion of chronic active T cell mediated lesion, probably group 2, grade 2. So I talked about IFTA. So IFTA is inflammation in areas of tubular atrophy and interstitial fibrosis. It's clear, right? So there is no confusion about this. And when we see a biopsy, visually, we can make a note of this and we can very well identify how much is the inflammation. So in terms of diagnosing this, there is not much of a problem. The problem is in how you apply that particular IFTA score to a given biopsy. So you can't just apply that just because there is IFTA, there is inflammation in IFTA, it does not directly correlate into a chronic active T cell mediated reaction. The reason being you have to exclude other causes, a multitude of other causes that includes viral infections, drugs, therapies, and other things which are that patient might be having. Once you've excluded those causes and you don't find anything, then you make a diagnosis of chronic active T cell mediated reaction. Now, basically, what it is a morphologic correlate of activity, right? We have seen that. And when you compare it with IFTA with no inflammation, this actually predicts the disease progression as a part of active injury process. And this is precisely the reason which was included in the BAM classification, because it was realized that these cellular infiltrates which are colonizing the scarred areas, they have been found to be independent predictors of graft outcomes. So that is where it was thought that we should be able to include these particular inflammatory components into BAM classification and grade them as the BAM hierarchical grading happens. Now, as I said, IFTA is likely to be a manifestation of TCMR when it is associated with features of an ongoing T cell illumination. Says you should be able to look at tubulitis. Maybe you can go back and see a history if this patient had previous TCMR episodes in the past. But this is done only after we excluded all other causes. For example, BK virus, any ABMR, any glomerulonephritis, and even obstructive etiologies. So obstruction and backflow also induces a lot of lymphoplasmacytic infiltrate. Again, that has to be excluded before you make a diagnosis. So I'm sure you have understood how difficult it is for a renal pathologist to actually make a diagnosis of chronic TCMR just based on IFI and tubulitis scores.
So,
And this is how it appears. So if you can see this, this is the capsule where I'm pointing right now. And you can see there is a lot of inflammation. It's as blue as I showed you in the first biopsy, but this blue is all involving areas of fibrosis. So this I is not I, this is IFTA, right? Because it is occurring in areas of tubular atrophy. And then depending on how much it is occupying, we grade it progressively.
Alok, sir.
Similar concept now is TIFTA. Now this
Alok,
was introduced in 2019 and
I'm sorry.
yeah, I'll conclude it. So I think there are last 4 or 5 slides. I'll just quickly finish it off.
Thank you.
And this, but at this point of time, does not have any place in the BAMF classification, but it is good to remember this. Now, finally, the point which I was coming to make in terms of the updates from the last 2024 meeting where it is heading, this is the last 2 slides in the presentation. So there has been no change in the TCMR classification. Now, as I just told, the alternative etiologies of inflammation other than TCMR, we have to start identifying actively, which we were not doing till now. And now we are creating a reasoning framework for tubular stage inflammation. Now, based on what all information we are gaining in the background, we are trying to create a framework for tubular stage inflammation. And we are looking more intently at mixed rejections. We are looking at isolated V lesions and trying to put them into a separate category and whether we will be able to treat them eventually or not. I talked about the activity and chronicity indexes, which will again be there in 2026 BAMF meeting. And finally, I talked about the biopsy-based transcript analysis, which is now probably the first thing it will do if it comes to routine practice, will eliminate the borderline category of T-cell mediated infection. So this is the overall scenario. And thank you for hearing. And maybe I can take up the questions if there are any later on. Thank you. Thank you so much. Dr. Purva, we can't hear you. I think you're on mute.
Yeah. Am I audible now?
Yes, yeah. Yes, yes.
Oh, thank you so much, sir. It seems like you are finding a needle in a haystack when you talk about finding one cell to declare somebody is having TCMR or not. But that just shows the complexity, because sometimes we wonder, we've done everything, and even then there is a creeping creatinine happening, and we don't know if it is a rejection or CNI toxicity or things like that. With that, I'd like to continue our the next session, the next part of our session, that is the panel discussion. And to begin that, I have a few pertinent points. As far as the literature is concerned, it says that TCMR does not cause graft failure. The paper published in 2012 mentions this. And the most common causes of graft failure are ABMR, BKV nephropathy, and glomerulonephritis. But I have a few questions. If the TCMR persists, it can give rise to de novo ABMR, which I'll highlight in the news next slides. So that is one question I have. Whether TCMR can cause graft failure or not needs to be discussed. The second thing, as sir has already mentioned, it is an Achilles heel to treat borderline TCMR. It's like, the signals neither red to stop, nor is it green enough to go. And the implications, long term implications of borderline TCMR are that if the IFTA continues on follow up biopsies, we may think that this is not rejection, and we may under immunosuppress the patient, or we may not be able to treat the patient properly. So this category of TCMR is difficult to treat. And the reason why TCMR needs to be spoken about is there are a few transplant physicians, or because of the cost and infections and things like that in India, we have resorted to no induction in certain cases. And whether when you not do not induce somebody, if they develop TCMR, is even if we give steroids later or an induction therapy later, can these lesions be reversed, is something I want to know from our panel discussion. And although I put this question 3 days ago to the two groups, that is the transplant group on WhatsApp and our group Nephrocon, and I received these responses that 27 participants, they said that even if somebody has haplomatch, they don't they don't give any immunosuppression, induction immunosuppression. And majority of them prefer giving less than 50% of the standard dose, and a few of them prefer giving a standard dose, that is at least 3 mg per kg of thymoglobulin or 6 mg per kg of graflon. um, so we are aware of the prevention protocol, that we give induction, or and then we give triple drug maintenance immunosuppression. But some cases, some patients still develop some sort of a tubulitis or T cell mediated rejection, and this whole panel discussion is about that. So I welcome Dr. Vivek Kute sir from Gujarat and Dr. Arvind sir Subramaniam. It's a pleasure to have you back, Arvind sir, for the second discussion on transplant series. And we begin this session with the diagnosis aspect of TCMR. So, to Wales, sir, Arvind sir, are there any situations where you would not biopsy despite of an abnormal Doppler?
Thanks, Purva, for inviting me again. Yes, see, as I've been using Doppler for many years, there are certain situations, and I see many times, whatever I do, even biopsy or a Doppler, our clinical approach is to rule out, not rule in. I will rule out first ABMR. If I anything, in the last meeting, we were discussing about some of the findings of ABMR, which is very classic on Doppler, like narrow spiky systolic pattern with the diastolic cutoff with the reversal and stump flow pattern, all these things I was telling about last week. But in a given situation, I know the haplo match and the DSA and everything, and the success of surgery. So based on that, I have some predicted risk beforehand in my hand. If a patient adequately immunosuppressed with induction as well as in the continuous phase of There are certain situations I may avoid, but my threshold for bias would be very low. Whenever I doubt, especially when there is a narrow systolic with diastolic reversal, in those situations I will do. Otherwise, a simple diastolic cutoff, patient is preserving good urine output. Doppler shows that no haziness in the on a bright mode. There is a basic mode of echo. You have a CMD is good. All these things will give me a clue that I may wait for 1 or 2 days. Yes, of course, but this depends on this the clinical context.
Also, sir, do you routinely repeat biopsies after treatment response?
Generally, we don't do especially in a ABMR in a follow-up I may do, but in a TCMR, if a biopsy proven even otherwise, and I'll just follow up my threshold below. But if a patient is non-reversing azotemia, in those situations, then my threshold will be too low to we'll go for again repeat biopsies to identify whether, because I have one more slide for that, and Alok Sharma also telling about that point, and TCMR is the perfect storm for future development of DSA, which exposes the cryptogenic antigen. So I may do biopsy if there is no normalization of azotemia. Yes, of course I will do.
Okay. So the next question is to Vivek, sir. So welcome to Nephrocon's webinar. Are you there? Hello.
Yes, yes.
Vivek is there.
Yes. Sir, in resource limited settings, is it always feasible to do to biopsy every graft dysfunction? And are there any practical alternatives that can be used? And
So for the Indian scenario, it also depends on transplant setting. There is a public hospital, hospital, and in facility available. So I can describe experience of our center since we are the largest public sector transplant hospital. We try to do the biopsy to come to the definitive diagnosis rather than empirical therapy. That is our approach, and we do DSA monitoring before and after transplant and robust immunological assessment before transplant. Like we do all the three tests: lymphocyte cross match, flow cross match, and donor specific antibody. So, how we should go, it depends on the cost, infection, immunologic risk, and hospital setting, and obviously finance of the patient. Because the 80% of the transplant services in India is in private hospital, and less than 20% is in the government hospital. So basically, a patient-centric approach should be decided for deciding this question, how we can give best solution to the patient to manage the risk of infection and obviously the limitation of the cost.
okay. So, going to the next aspect, this is the evolution of BANFF, which Alok sir has already discussed in depth. And he's already mentioned that there is going to be some transcripts that are going to be now included in the near future. But these are already exist. Some aspects of molecular testing, diagnostic testing are already included in the BANFF. And this is the timeline that has been. With that, I'd like to ask Sir, Alok Sir, where do you see BANFF evolving, and should it move towards integrating molecular diagnostics into routine reporting? You've already mentioned that, but just like a quick comment on it.
Yes, I think this is exactly where we are heading. And although the timeline is not clear where we will be able to do it seamlessly, it will be a very difficult and challenging thing. But yes, of course, for selected conditions, we will definitely be using it. And I think the guidelines are also getting clearer now. Probably from the next guidelines as they evolve, there will be specific guidelines. So it won't be a blanket testing. You can test based on the clinical indication. I think that's the most effective, reasonable, and economically viable way of integrating molecular diagnostics into your routine reporting. And I definitely see that happening in very near future.
Right. So this burning question that TCMR, does it translate to de novo ABMR, is something I would want to know from Alok sir and from our panelists. Theoretically speaking, sorry, sir. Yeah. So TCMR basically predisposes and increases the donor antigen expression on graft endothelial cells, and that becomes a target for recipient antibodies. And that is why, even though TCMR is rare, or it's in a declining stage, we have to be very cautious while treating, because these are the cases wherein you don't know how suddenly a patient who is compliant to his or her medicines develops ABMR. So that point is what I would like to discuss with Alok sir. Have you seen in clinical practice in your center, when you see biopsies for TCMR, do they have you seen follow-up biopsies wherein they translate into ABMR?
So this is a very interesting thing, which this is interesting development which is happening in the transplantation field, this particular concept. And of course, we don't have enough evidence as of now. So this is an evolving field where we don't have a very robust evidence in terms of well-defined or well-performed clinical studies. But yes, if you look at the, if there is a mixed rejection phenotype, right, which happens later on in the transplant period. And as you have just told in your, just immediately you have told that it is the later part of it when the patient is apparently well, it's compromised, doing well with his medication. And then when you see these mixed rejection, that is the point, that is the area where we actually start thinking in terms of, and I feel this is a very real thing. And as we see more and more cases, this is going to evolve. But I think those are the set of cases where we will definitely be looking at. So you have a mixed rejection phenotype and later down in the allograft live, and probably that's what it is showing, that it is showing that probably a T-cell mediated rejection has exposed the epitopes and led to a super added ABMR. And having said that, the mixed rejection phenotype, we talked about it. So we were just analyzing our data. So in the first 15 days of post transplant period, the first 2 weeks, roughly half of them have a mixed rejection phenotype. So that's one set of area where which needs to be studied, and the second set is the later down in the period where. So I'm sure this is an evolving field, and I completely concur with your opinion and point which you have raised on this. There is definitely a possibility. Yes.
Also, sir, my second question is, would you recommend protocol kidney allograft biopsy to catch TCMR early in high-risk kidney transplant like ABO incompatible or second transplant?
Yeah. Again, so probably the answer almost is the same in the sense protocol biopsies. So I was part of one of the earliest protocol biopsy studies which we did at AIMS in 2010 or 11, and where we did a 0, 6, 12 kind of a protocol biopsy approach. Although what came out of it was more in terms of chronic calcium inhibitor toxicity. But yes, there were subclinical cases where we could put it into either a PCMR of a borderline type or even a 1A or 1B type, which were, because it was a study with intent to treat, they were treated and they did well. It's difficult to say because they were not having renal dysfunction, but the long-term follow-up would have told what exactly happened. Having said that, again, there are no clear-cut, there are conflicting studies on that. But on a generic basis, I think if, especially in light of TCMR actually giving rise to ABMR, this part becomes even more important. So in high risk patients or selected clinical conditions, doing protocol biopsies is definitely a very, very important thing, especially if the patient has had mixed rejection in the early part of his post-transplant period. I think that forms a good clinical subgroup where you can actually start looking at protocol biopsies and following these patients more robustly so that you can prolong their graft life.
Right. So my next question is to Arvind sir. These questions are a little similar, and because you have been doing Doppler so often, you would like to know if can TCMR features on biopsy be correlated with TCMR clues on Doppler? And another question is, can Doppler differentiate TCMR from ABMR, CNI toxicity or obstruction?
Yeah, first question, I'm afraid I don't think so, because TCMR cannot reflect anywhere on a Doppler.
Yeah.
So you can diagnose ATN, CNI toxicity and ABMR, but TCMR per se you cannot diagnose on Doppler, because that is a very difficult to, because the TCMR involves most of the interstitium and vascular. If pathology is not there, it will not be reflected on anything on biopsy. The second question, yes, of course. The last time we were discussing, I think it's a long set of slides. We can go through rapidly. I'll go. This is a Nandi pattern, and just I'll finish by 7 minutes if you allow it me time. Because there is a very interesting points are there, and
Sure.
just go ahead and just keep going. Can I have a control? No, you don't.
You can ask me to do
Yeah,
go.
please go ahead. This is a typical that is a peak systolic, and the x-axis shows the the baseline. The y-axis basically is a scale with this peak systolic velocity and end diastolic. With this, the basic foundation of a spectral Doppler you can diagnose. And the kidney is the one area where you can have a continuous systolic and diastolic flow. It is all based on that systolic narrowing and the diastolic cutoff. You can understand there is a resistance developing inside the graft, and there are the two RI and PI. PI is neglected because there are so many factors apart from RI is in the graft. RI is just an engine light which shows the signal, and PA pulsatile index is second opinion to the RI. I think people are often forgetting to look into the PA because in RI we can see only the peak velocity, in a PA we'll see the mean velocity goes beyond the graft, and it shows a systemic. It's a big topic itself, but ideally if you have RI of 0.7 and PF less than 1.3, you need to be more than 10. And on the 10th day of transplant, this is ideally functioning graft. This will set into the motion in your thinking that in an ABMR, the entire system will be changed. But when you ask a question about the ABMR, CNA toxicity, obstruction, of course, in obstruction, you see the very obvious dilatation of the pelvic calcium system, or till the ureter, it may even till the anastomotic to the bladder level, you can see the thing. But if you have an elevated creatinine in any obstruction initial phase, you will have a normal flow, normal systolic diastolic flow. That itself says there is no immunological issue. Now you revise your surgical technique, and anything went wrong during anastomosis, any long segment of ureter which was devoid of any vascular supply during the harvesting, all these things you have to take into account. But just exactly on the second month end, third month beginning, spilling into fourth month, if you get a dilatation, if you have documented properly on table, just after the transplant, after digestion removal, if any patient develops a new onset of pelvic calcium dilatation, then definitely you have to watch closely. The only sign what I observed because I'm getting this kind of patient for various centers for correction, you will have the gradual elevation of this thing. I will call it as a maple tree, then cobra head, and pufferfish appearance. All these things, the system will get dilated more and more, along with the creatinine elevation. This is the one clue you can get for obstruction. For a CNI, there is a definite pattern. I think time is limited for today.
I just go through the slides quickly.
I just go rapidly. Okay. So this is just go the ATN. See, most of the time, this is the broken tower appearance. Just go fast, and we can see. This is one patient we had in the past. See this, if you see this kind of a patient with only systolic base, no diastolic I know there is no reversal. I'm very confident this patient might be having ATN or simple TCMR. So this I'm giving confident. You asked the first question whether you go for a biopsy on these patients. If I'm very confident on my Doppler finding, the rest of the findings I correlate, then I will not do biopsy for this patient. So just go ahead and just keep browsing, and the next one. See, after some time, this patient started improving. So the diastolic cutoff was, I think, is regained, and the patient developed a normal Nandi pattern. So this is what the importance of Doppler in certain situations. So go ahead and go ahead. Okay, just keep moving forward so we can finish it fast. And keep one more thing, and it is all video files. Just keep moving forward. Yeah, if you have a patient with a suspected TCMR, you are or ATN for any reason, but clinical. If you have any patient developing reversal, I want to stay by just a few seconds for this slide. If anything less than 30 days, anything more than 30 days, severe ATN with edema can have a reversal, and rejection, graft vein thrombosis, hematoma, kink, late post in a low cardiac output. This is a very important point, low cardiac output. I have a lot of slides for that. To the very important teaching point, anything more than 37 beyond, if you get any reversal, you have to rule out a low cardiac output, new onset of any cardiac problem. Rejection. So just goes to the next slide. So this is what we get in reversal. Go next slide. So see here, I have a doubt here. This patient has got a narrow base with the diastolic reversal. I'm doubtful whether this patient I'm dealing with a severe form of TCMR with the severe interstitial edema. or simple ATN. Here I will go for a biopsy and then rule out and any concomitant other things are going on, antibody injections along with the TCMR. And here this patient had a predominant TCMR with ATN. This patient recovered well. So go ahead. So this is a biopsy. Previous patient I did a biopsy. This patient I did a biopsy. I was confident this patient was responding to simple pulse steroid. Next one. So the all clinical context, if you work closely, every day you have to do Doppler. Morning and evening you Doppler finding. Well, hemodynamic changes are very quick. It will give a lot of clue. Next thing, the patient started having, so this is the one slide, next one.
Yeah.
Next one. So this is one slide which gives with reversal, without reversal. Without reversal, I may wait. With reversal, I may do, because it may be having some kind of severe ATN, patient with the TCMR with the concomitant ABMR. So anything in a Doppler finding, any reversal, it needs a biopsy to be done and should be confirmed with the other next diagnosis along with TCMR, simple ATN. Next one. This is the one teaching point. The ABMR I sold. This is a finger pattern. If you just start observing, especially if you get to do a cadaver transplant. See, if you get a long cold ischemia time, soon after the transplant, you don't get output. If you next 24 hours, 48 hours, you get this kind of pattern. This is typically of ischemia reperfusion injury. Just go ahead. Good. Now I'll show some of the slides. So these are the one. So next one is I just named it as a finger up sign because just you look from behind the finger up sign. So next one, the typical of. Then comes last time we were talking about this one, ABMR. This is a very bad sign, stump flow pattern. If you get stump flow pattern in on a Doppler, especially spectral Doppler, you are dealing with a losing graft. So in this kind of situation, I will not venture into doing any plasmapheresis with a waste of money. I'll just accept. I'll go for early nephrectomy and just can at least remove all the memory cells which are being produced during this time. Next one. So keep moving forward. Okay, this is all other slides. This is all finger up and pattern and stump flow pattern. Next one. This is actually biopsy. If you do a biopsy, you'll get a blackish tissue, or the segment of long tissue, core tissue will be intersected by multiple clot-like factors. This is a first classical macroscopic examination. You can be sure that this patient is having some cortical necrosis. Next one. So this is what the thing we did. So patient got ruptured, graft. So when you get a stump flow pattern ABMR, this is what you will get. So early, go for early, then waiting period will give you DIC, you lose the patient, hemodynamic compromise. So earlier the better. So Doppler will give you a proper guide, stump flow pattern. Next one. Next one. So these are the stand. These are some of the, I called as these are stump flow pattern. Last time we were talking about the last webinar. Next one. So this is a very bad sign. So next one. So this is what I just put in a simple one thing. This is called a doubling spine, very narrow systolic with a diastolic reversal. I call this a doubling spine pattern. Thorn pattern is just below. And next on the TAC toxicity, very classical. I'll finish within one minute. So TAC toxicity. See, I just got it to know from whenever I'm doing Doppler in a pulmonary hypertension. Anything in an accelerated, and the pulmonary acceleration time, if you are well versed in the echo, you will get a M pattern. So normally the pulmonary acceleration time should be more than 1/10 second. Then I started observing the same finding in the kidney. This is a reversal actually. If you flip the same pattern, can you make it bigger? Yeah, this is what you will get. So that is the reversal of the pulmonary hypertension pattern. Accelerated time on the pulmonary flow. The reversal you get. The first elevation of systolic followed by the next elevation of the systolic peak. So if you get a first peak more than second peak less, it's not TAC toxicity, because most of the CNA toxicity happens in upfront arteriole. That's my assumption, because multiple millions of nephrons in the blood, in the kidney. The first there is some stasis, then some holdback, then again second push from the systolic flow. So first will be some resistance, then second will be then this is a typical of TAC toxicity. If you start observing, definitely you will have more level. So of course, so this is what Doppler comes in handy. Next one, if you don't treat it, I think somebody was coming in the group, if you don't treat TAC toxicity, it will become chronic very quickly. This is what we see in the recent times. So you have to identify early and you have to treat it early. This is what the pulmonary, next one. So this is what their flow we'll get. If you have a severe pulmonary hypertension, you go to the pulmonary flow. Next one. The video file, Purva. Let's go to the next one. This is what you get. If you put up cursor, your echo probe in the pulmonary valve, you get the first more peak, then it's less systolic peak. It's like a M pattern. Then this called This is a typical of severe pulmonary hypertension. You flip it more up, you'll get in a kidney patient. So this is what I got an idea about doing this tax toxicity thing. So of course, the nutshell, yes, you can differentiate, but TCMR you cannot say on Doppler. You can say ATN, ABMR, tax toxicity to some extent. I'm not saying 100%, to 90% you can say. The obstruction, I said the obstruction would be, these are the recent patients at 12/8. You see the date. This patient from other center is absolutely normal finding. This was the misleading the treating nephrologist. But when you keep observing every day, the creatinine was 1.8, 1.9, 2, 2.9. So finally, the patient came up with 8 creatinine. We had to do a re-anastomosis of the ureter to the bladder. So of course, so obstruction will not show anything. You have to observe very closely your creatinine level. The rest of the things you can diagnose to some extent on Doppler. So this is answer to your thing. I think it's a long set of slide, but I made it very fast.
Thank you, sir. Actually, we are grateful that you've actually taken the pains to do this because it is really insightful, and it becomes easier for us, especially when the biopsy report is probably going to come 48 to 72 hours, and you're just waiting what next. So in these scenarios, these findings are extremely important. So thank
More
you.
than that, Purva, I may take just a few seconds for time. See, most of the time when we deal with the ABMR, hastily we just tend to do more plasmapheresis. Each plasmapheresis costing about 40 to 50, depending on the even minor center, major center, about 1 lakh. If you do 5, you exhaust every financial so I think you will not go for next kind of treatment. So I think Doppler will give a great clue. This is not 1 or 2 cases. Hundreds of cases in last 15, 20 ever since I started doing ultrasound. So this is what my experience.
I appreciate that a lot, sir. So coming to the last bit of our TCMR session, we all know that we treat TCMR with pulse prednisolone, and if there are severe cases, there are the transplant physicians who do give ATG as a rescue therapy, but I don't know how much of that works. And of course, there's a few other things like optimizing immunosuppression, etc. So, related to treatment, my next question is to Vivek, sir. Do you use steroids alone or escalate to ATG in borderline cases if graft function is preserved?
Yeah, so basically, when we decide about this question, we need to see what is overall induction therapy, maintenance therapy, levels of the CNI, immunologic risk stratification. Generally, we use steroid therapy alone. That is more common approach. And we give thymoglobulin only in the biopsy confirmed cases. Many times we need to give the empirical therapy.
Right.
So we need to see the overall balance while proceeding forward.
Right. Sir, and how aggressive are you in treating late TCMR? Like probably a year later. It must be rare, but do you aggressively treat them?
Yes, basically all immune injury we have to manage them in appropriate way to improve the long-term outcome. And while deciding the level of anti-rejection therapy, we need to keep the optimum balance between the overall immunosuppression state to prevent an infection risk also.
Right. So, and so how do you approach TCMR in case there is a coexisting infection?
So again, this is a very common scenario in the India, like coexisting infection. So whenever there is a BK of viremia, obviously we will not give additional immunosuppression. We should manage only with the IVIG because infection is more important as compared to the immune injury. The similar situation is applicable for the tuberculosis and COVID. So basically, infection takes priority over managing more intense immunosuppression for the rejection therapy.
Thank you, sir. Arvind, sir, how do you manage TCMR in patients already on maximal maintenance immunosuppression?
Oh, this gives a clue that if the patient is developing TCMR, I think many people and all, like Sir and you, everyone was telling about it's a declining entity, TCMR. We always see the mixed acute rejection, subclinical or borderline that have been extensively discussed. And ABMR is the secondary cellular component. The primary driver may be antibody that attracts T cells. So basically, TCMR is a perfect storm for future ABMR ground. So this is what I made a slide today. Just an episode of TCMR can be a potential harbinger of late development DSA and chronic active ABMR. Injury begets injury hypothesis. Exposure cryptocandigen, de novo antibodies. So in a nutshell, if you have a patient adequately, if for example, if you have pharmacogenomics approached based immunosuppression therapy, for I do a pharmacogenomic patients extensive metabolizer, poor metabolizer, I just nullify all the vacuum which is before transplant. I'm totally convinced about the adequacy of the immunosuppression. Even patient develops, even then patient develops TCMR. I'll ask my pathologist to look into some microvascular pathology, revise the pathology. It needs a lot of vigilance, and I'll go for a high risk other things like patients having anuria, raising azotemia, non-responding to. Then I'll go with because in my opinion, my understanding, not opinion, understanding that the two arms of adaptive immunity does not happen isolated. It all hand together. That's what the thing. So I'll be very aggressive. When a patient adequately immunosuppressed, I'm just doubting about my this thing. I'd be a little more, in my approach. I may include ATG if a patient has got on biopsy. If you do a biopsy, you do a 2E or 2B, along with, I said, this kind of Doppler findings. I'll take into many things into account. I'll optimize more. I'll go for, I'll strategize the both arms of adaptive immunity, giving more of a ATG if the patient not responding in the immediate transplant period, not in the late transplant. Late transplant is a different scenario altogether.
Right.
So I'm just doubting about whether patients are in adherence, all this, whether I've been adequately treated based on pharmacogenomics of therapy, immunosuppressant therapy. It's a very complex scenario. It's not a very straightforward thing. So we have to doubt many things here. I have to go and revise the pathologist. I ask my pathologist to revise a slide, and everything I just take into account.
With Alok sir's lecture, I feel TCMR is probably rare is because we are not able to label it properly, or there's so much happening in the definitions that even IFTA, if you see on the slide on the biopsy, we will not have a final conclusion by the pathologist that this can be TCMR. So that is something that which probably should alarm us.
You stressed a point very nicely that one mononuclear cells in the endothelium is involvement. You stressed the point again and again. That's a very nice point you underlined. Probably we have to take into account. So that's why we put the slide actually.
Yes. So rare TC. I don't think TCMR is rare, especially when there are nephrologists who are not giving induction agents to.
So the potential adjustment will be there will be a disproportionate azotemia in the background of TCMR biopsy, 2A, 2B, 3, progressive Doppler output, spectral Doppler. All this will give an idea that it may precede. So here the answer is the TCMR as such may precede ABMR in the coming weeks. So probably I have to be more vigilant on my therapy, focusing on modulate on both arms of immune response, adaptive, both cellular and cellular antibody. This is what we have to be very vigilant on these patients.
Right. So we are short of time, but I think I'll just have some closing remarks and probably we can discuss at ISOT or some other meeting. I have two pertinent points. Are we misclassifying or not able to classify patients accurately into low risk or high risk categories for receiving induction? I don't expect an answer now, but I think we are. Because we hugely rely on immunological assays and cross matches and things like that. But I think what needs to be remembered that, age of the patient, comorbidities, prior transplants, the dialysis vintage, they all also contribute to the immunometer, which one of the nephrologists, I think Dr. Hariharan from the States, had constantly reiterated when he spoke about long-term complications or the long-term outcomes of graft in his career of transplantation. And the evolving approaches are there, but they are still in pipeline, and we are not able to utilize them to the fullest. And the second question I have is, the reason why I'm asking is, many a times we tend to treat infections in a patient, and probably, let's say, 10 days after the infection is treated and the patient we declare that culture is negative, everything is okay, now let's go ahead with transplant. that window, I feel, can contribute to de novo antibody formation, which may have a query, molecular mimicry that can cause ABMR. And should that category of patients who have recently recovered from any sort of a major infection, let it be sepsis, a pneumonia, or a pyelonephritis, or whatever be, there should be a window. And I think these patients also should be categorized in the highly sensitized ones. I just want a quick comment about this from Vivek sir and Arvind sir.
Yeah, so we need more data and Indian evidence about the risk stratification because we are practicing as per the KDIGO guideline about high risk and low immunologic risk and deciding in the induction therapy. So it need more robust data to answer this question.
Right.
Let
Arvind sir?
me let me prepare myself. I think there is no answer for this. You asked a very tough question, actually. So it's
Sorry,
very,
but the reason why I'm asking is we sometimes have cases where we have done everything perfect on paper,
yeah,
and
right.
on biopsy you see some vascular, microvascular injury or some
So,
evidence that this
yeah.
is rejection.
Yeah, correct. When Abraham Lincoln was asked, many in the Senate member, somebody was asking, "Why are you asking foolish questions?" He said, "There is no foolish questions, only foolish answers. I may give a foolish answer to you. Let me reserve for it to the future. We
I
will
just hope
discuss it."
I've not asked a foolish question
No, no,
also.
no, not a foolish. There is no foolish question. I said it's a very sensitive, very nicely formulated question. So I should not answer foolishly. That's it.
Okay. So with that, we would like last comments from Alok sir. What is your opinion on FFP, that is, I think, formalin preparation
It's
based
paraffin
molecule?
embedded, yeah.
Yeah.
So I think currently there are only 2 or 3 platforms which offer biopsy-based transcripts, and only one of them gives a luxury of doing it on FFP. So you don't have to take a separate core and other things for that. And I think as more and more systems come into place, so we as nephrologists, as pathologists, we have to find out ways where we can induce new research into that area and get new techniques to us. So if we don't find indications, that development won't happen there also. So right now there is only one platform which allows this, but unless this develops, I think it will be very difficult to integrate into routine practice. Yes, definitely. It has to be. And once it is done, it will definitely, it's already there since 2013. Only thing, it will get more adopted by the general community as once FFP based platforms become more accessible and affordable, both the things.
Right. Thank you, sir. So with that, we've had a wonderful session on Teachers' Day, and you three have been our great teachers for the day. So thank you so much. I wish you all a happy Teachers' Day, and I conclude this session. Thank you so
Thank
much.
you. Thank you so much. Thank you.
Thank
Thank
you.
you.
Thank you. Bye.
Good, Vivek.
Thank you, sir. Thank
Alok,
you.
sir, good night.
Thank you. Thank you, everyone. Thank you. Thank you, everyone.